Good evening, everyone, and welcome to today's webcast, Dispelling Psoriatic Myths. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in tonight's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right-hand corner. You've joined the presentation listening using your computer speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane, and the dial information will be displayed. You'll have the opportunity to submit text questions to today's presenters by typing into the questions pane of the control panel. You may send your questions at any time during the presentation, and we will collect these and address as many as possible at the end. Before we introduce today's speakers, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice for millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, log on to our website after today's program at www.psoriasis.org. One way we improve the lives of those with psoriatic disease is by offering a patient navigation center. Whether you've been newly diagnosed or have lived with the condition for years, our team of experts can help you find the healthcare providers, discuss treatments, and help with insurance. We'll work with you one-on-one to support your journey towards a healthy life. During the month of October, NPF's Patient Navigation Center is offering free goal-setting sessions to help you live better with psoriatic disease. When you sign up for a free session, you'll be paired with your own patient navigator who will work with you to set and achieve measurable goals. Together, you and your navigator will create a personalized plan, which will help you achieve your health goals. Your navigator will also help track your progress along the way. To schedule your free session, you can visit psoriasis.org/goal-setting, and when you visit the page, you'll be asked to complete a short survey to help your navigator better understand your personal health goals. Next, on behalf of the National Psoriasis Foundation, we'd like to extend our thanks to Eli Lilly and Celgene for their sponsorship of today's educational webcast and for making this presentation possible. Now I'd like to introduce our first speaker, Jason Oberdick. Jason is a dermatology physician assistant with Forefront Dermatology in Pittsburgh, Pennsylvania. He graduated with a master's degree from Duquesne University and has been practicing dermatology for 13 years with a special interest in psoriasis over the last decade. He has lectured on psoriasis for many years and finds successful treatments of psoriasis among the most rewarding aspects of his career. He lives in Cranberry Township, Pennsylvania with his wife and 2 sons. Welcome, Jason.
Hello, everybody. I'm really excited to be with you tonight, and I just want to first off thank the National Psoriasis Foundation for hosting this. I do all aspects of medical dermatology, and I have to say, in my opinion, the National Psoriasis Foundation is far and away the best patient advocacy group for any of the disease states that I see, and I just really think they do a great job both for patients, for providers, and just educating everybody, providers and patients, about the disease, and also providing ways to make it through what can be a pretty difficult disease sometimes. I'm very excited to be talking to everybody tonight. Normally when I do talks on psoriasis, I'm talking to other providers or office staff, and they're not really who's important. What's really important are you who's tuning in tonight, the patients that live with psoriasis every day. It's your opinions that I certainly, and your happiness and your well-being that I certainly place ahead of all the other people that I get to interact with. And so I'm just very excited to be talking to you, and I hope that somehow this talk with myself and Dr. Bourne can really help you manage your disease and hopefully just live a better, healthier life with your psoriasis. So we'll get started on the slide deck here, and we're going to talk first about some facts about psoriasis, and then we're going to move along to talk about some myths about psoriasis. And I think you'll be interested to see these because I'm sure that some of the myths that we'll talk about you've been confronted with in your daily lives. So psoriasis is a chronic inflammatory autoimmune disease that affects over 8 million people in the United States. Autoimmune is a little bit of a catch-all phrase. I think it's probably best, and that's the phrase we use to describe psoriasis, but I think it's probably best described as a immune dysregulation, or the immune system is altered. It's just not regulated properly in patients with psoriasis. It's not that your body's attacking your skin cells per se. It's that your body's immune system is just overzealous. It's overactive. It's hyperactive. Something triggered it, and now it's hyperactive. And as we go along here, we'll talk a little bit more about that here. Try to advance the slide here. There we go. So what causes psoriasis? We know the big thing is there is a genetic predisposition. And so a lot of times it's just sitting there in your DNA, and then all of a sudden something comes along in your life and it triggers it. And we'll talk a little bit about what these triggers are in a minute, but one of the things that, I always try to tell my psoriasis patients, hey, if you have children, they're not doomed to get psoriasis. Here you can see about a 14 to 28% risk of developing psoriasis. If the person has one parent, or if a person has two parents, you can see it's about 50-50 odds whether they'll get psoriasis. So I do try to encourage my patients, and then also patients or sons and daughters of people with psoriasis, that it's not necessarily inevitable that they'll get psoriasis at some point. However, it's certainly an increased risk, and certainly sometimes when we have patients in that we're not sure, is this eczema, is this psoriasis, a family history can definitely play a big role in helping us determine exactly what disease state we're dealing with here. So what about triggers? All sorts of things can affect psoriasis, triggering the onset, worsening it, or even making the symptoms better. Some known triggers that we have are certain medications. Some of these medications are things like beta blockers that you use for high blood pressure, Plaquenil. Sometimes people with lupus are on Plaquenil, or other autoimmune diseases are on Plaquenil, and sometimes that can trigger psoriasis. Lithium is another common one that's used for various mental health disorders. So there are a number of different medications, and certainly that's something that you can just be going on along in life, and if you have that genetic predisposition and you're put on a beta blocker, for example, that can pull it out. So it probably would have come out at some point anyway, but we don't ever know that. Certain illnesses can trigger psoriasis. The classic one is strep throat. I mean, I see that time and time again in my practice where a patient has strep throat and comes in. The only good thing about that is occasionally with strep throat, they get a type of psoriasis called guttate psoriasis that is not a permanent or chronic problem. So whenever we have that, I mean, sometimes we can treat the infection, and sometimes the psoriasis goes away, but sometimes it's also the start of what will be a chronic disease. Injuries to the skin can trigger psoriasis. We have a kind of a weird word called or weird phrase called the Kebner phenomenon, where an injury to the skin, as it heals, you'll get psoriasis around that injury. We see this all the time. I had a patient that got into a motorcycle accident and got road rash everywhere, and as he was healing, he just developed psoriasis everywhere. And that's something that sticks out in my mind. And I've had other people that have gotten it around piercings. So it is something that can bring it out. We also know that stress can trigger psoriasis. Whenever I started in dermatology 13, 14 years ago, I kind of, scoffed at the fact that, or at the notion that stress could trigger skin disease. But I'll tell you, I have seen it time and time again. I can't tell you how strongly I think there's a correlation between stress and skin disease, and particularly psoriasis. Particularly certain types of psoriasis I'll see be a lot worse whenever patients are very stressed out. So that's a real thing, and I have seen that bring it out in people, whether it's a breakup or a death of a family member. I've had a number of patients in those situations where that was their presenting symptom to me, or presenting situation to me. And then, of course, diet and weather can have some implications. And I think down the road here in this talk, we're going to talk a lot more about diet. I know Dr. Bourne has some great information on that, and is definitely an expert on that as well. And, where I live in Pittsburgh, weather can play a role. Summers are great. People can do great with psoriasis, and certainly the colder weather tends to trigger it. All right, we'll move along here. Okay. So different types of psoriasis here. We have plaque psoriasis. That's the classic one. You have guttate psoriasis, where you get the speckles everywhere. That's often after a strep infection. You have inverse psoriasis, which happens under the armpits, under the breasts for women, and in the groin area. And then you have a pustular variant. And this pustular variant can be very difficult and oftentimes happens on the palms and soles. And then you have erythrodermic psoriasis. And unfortunately, patients with that oftentimes not only look like burn victims, but they can have symptoms and difficult health problems like burn victims, such as problems with fluid retention and things like that. So it can be a very, very big problem. All right. So as we know, psoriasis can be mild, moderate, or severe. Mild psoriasis is about 3% of the body surface area affected. Moderate is about 3 to 10%, and that's when we start saying, well, you can start using more aggressive medications for it. But severe psoriasis is more than 10% of body surface area affected, or presence of psoriatic arthritis, or vulnerable areas involved. I really want everybody that's listening, if you want to take one thing out of this slide, and really out of the last 5 minutes I've talked, this is an important fact to me. Even if you have just a small body surface area involved, if it's in a vulnerable area, then it can definitely be considered severe. And if you came into my office, I would consider it severe. So if you had your scalp covered, if you have psoriasis on your genitals, if you have psoriasis on your hands and you're a piano player or a bank teller or a teacher where your hands are seen all the time, I would absolutely in my clinic consider that severe psoriasis. So I encourage you, if you're seeking help for your psoriasis and it's not a big body surface area, but it's in a very difficult area, and somebody is not treating it as severe psoriasis, I really encourage you to find somebody that will, because that certainly deserves aggressive treatment there. So psoriatic arthritis is an important thing to bring up. I used to be terrible at asking about this and treating this, but I've certainly gotten better about this throughout my career. About 30% of people with psoriasis develop psoriatic arthritis, and this type of arthritis is very inflammatory, and it can have all sorts of manifestations. Common things are back pain or stiffness, pain in heel or bottom of the foot. I think Achilles tendonitis is a very specific sign for psoriatic arthritis. Morning stiffness. So if you are a person that when you get out of bed, you just can't get the stiffness out, and it takes you a half hour to get it out, and then you're okay the rest of the day. Particularly if you have skin disease, that could be psoriatic arthritis. It can cause fatigue, certainly reduce range of motion. The classic sign is sausage digits, we call them, where the fingers and the toes swell up like sausages. You can see nail changes. And then I think another underappreciated thing is redness and pain of the eye with some blurry vision. That's something that can sort of also be associated with psoriatic arthritis, and I certainly am not the best at looking for that either. So that's something to think of as well. So we have a number of different treatments for psoriasis here, and I'll just spend a minute on this slide because you have all used over-the-counter treatments. You've all used topicals. I used to treat psoriasis and other inflammatory dermatoses with topicals, and I think I had an unrealistic expectation for patients. I mean, if you have a small plaque on your elbows, it'd be annoying to put topical medicines on, whether they're over-the-counter or prescription. But if you have psoriasis covering a larger part of your body or hairy areas or things like that, I totally understand how that is just a very unsatisfactory way to treat your psoriasis. I never really understood it, but then a few years ago I had a contact reaction to a sunscreen I was using, and I had to put strong topical steroids on my body for just a few days, and it about made me crazy. So it gave me a lot of empathy for my psoriasis patients, because it just really is a pain in the butt. So I certainly still try to help everybody that it's appropriate for to treat with topicals, but I also have certainly become more proficient and more aggressive with some of my systemic treatments as well. So before we talk about the systemic treatments, I do want to mention phototherapy there. You know, as dermatologists and dermatology PAs and NPs, we don't like a whole lot of ultraviolet light to the point where you're putting yourself at risk for skin cancer, but we do know that phototherapy or ultraviolet light can absolutely help your skin disease. Now, the best method of this is a type of ultraviolet light called narrowband ultraviolet B, because that is a type of light that we really don't see any increase in skin cancer with, at least in my opinion. I feel like the studies are pretty conclusive that that's pretty darn safe. Now, the trouble is you can only get that at your dermatologist's office typically, or there are some home units available as well. But that certainly is also something to consider whenever you're looking at psoriatic treatments. One last treatment that we have to talk about here that I want to spend 30 seconds on is systemics and biologics. Traditional systemic medications such as methotrexate or cyclosporin, you know, they help some, but they really do have a fair amount of toxicity to the body. Methotrexate is very hard on the liver, and cyclosporin is so hard on the kidneys and other organs that unfortunately you can't be on that for more than a year. So those are the two traditional ones. Soriatane is another traditional systemic, but sometimes that's limited by side effects that people have. But I really want to mention biologics because this is just a totally, it's just been a total revolution just in the time that I've practiced dermatology, 13, 14 years. When I started, biologics really weren't used that often. There were some out, but not a lot, and people were afraid to use them. But over the last 10 years or so, it has just been a complete and utter revolution in the treatment of psoriatic disease. And while there are no treatments that have zero side effects, at least in my opinion, there's always a side effect of something or a 1 in a million thing that could happen. I do feel very strongly that these biologics have great efficacy with very small, not zero, but very small risk. And I always tell that to patients. It's not a zero risk, but it's also maybe not quite as bad as we hear on the commercials on TV. So that's something that I'm very passionate about, is for patients that do have very severe disease or even moderate to severe disease. I feel like we do have some great options that weren't there 10 years ago. So that is part of what really fuels me to be enthusiastic about psoriatic treatment. So here, we can go along to the disease myths, and unfortunately, some of these will probably hit an emotional chord for some of you because you've been through this and you've seen how it feels to be looked at. For this first one, for example, psoriasis is contagious. We know for a fact, obviously it's not. Every single psoriasis patient that comes into my office, I put my hands on and touch their plaques and feel the thickness, and it really gives me an idea of how they're going to respond to treatment, and it also helps me to connect with my patients. And it's amazing that even in 2016, we can have people that go to school and I've had people sent home from school, young people that have psoriasis and need an excuse to be able to swim in gym class with their classmates because of their psoriasis. School administrators think it's contagious. Bosses at work think it's contagious. People at the beach think it's contagious, and it is absolutely 100% not. And you all know that, but I think that's something we really want to get out into the public eye too, is that it is not contagious. And then the next myth, psoriasis can be cured. Unfortunately, at this time, psoriasis can't be cured. It is something that we can very much suppress, and it is something that we can turn down the intensity of from a boil down to a simmer. But unfortunately, we're not able to completely alleviate that now. Now, I try to follow the research on it pretty closely and on psoriasis pretty closely, and I don't know how this is going to happen, but you know, I'm 39 years old. I really feel strongly that in my lifetime there's going to be something that, if not a cure, kind of a pseudo cure for psoriasis. I just believe that we're making such progress in the field of immunology that I think there is going to be something that happens sooner rather than later. And you know, I think as a psoriasis patient, I just hope you all can have some optimism, because there is a lot of good news out there. Another disease myth that's actually not a myth: psoriatic disease is linked to mental illness. Depression may actually increase the risk of developing psoriatic disease, which was an interesting finding back in 2013. I will also say that it's a two-way street. Psoriasis is very much a cause of depression in many people, or at the very least is very strongly associated. We also know that psoriasis is very strongly associated with an increase in suicide. So, you know, those of you that have suffered with it can certainly understand and know that, you know, this is something that there's absolutely a correlation between psoriatic disease and mental illness. So here's another disease myth: drinking coffee will make your psoriasis worse. That is false, and I would also agree with that clinically. I have never had a patient where I really have diagnosed that their coffee drinking makes their psoriasis worse. The only thing I really think that affects in skin is rosacea, which is flushing of the cheeks. I think otherwise it's quite safe to drink your coffee and enjoy it. All right, we can go to the next slide here. So drinking alcohol can make your psoriasis worse. Unfortunately, I hate to tell everybody, but this is true. And alcohol definitely makes psoriasis worse, mostly by dilating blood vessels. That's how it works. And this just kind of lets all those proteins and cells in the skin just to reach the skin more easily. And unfortunately, it's definitely a trigger. My story about alcohol is I have a patient who I had on a biologic, and he was admitted he was an alcoholic, and he totally was upfront with me about that and struggled with his alcoholism. And he would, you know, just wasn't doing well with the biologic, wasn't doing well. And then one day he got sober. It's a wonderful thing. He's now a really strong proponent of Alcoholics Anonymous, but he got sober, and honestly, on the exact same dose of biologic, he went from probably 50 to 60% of his body surface area being covered to about 1% now. He is almost perfectly clear and has remained almost perfectly clear, being sober for about 4 to 5 years now. So such a clear-cut example to me. And not everything's that dramatic, but I think also not everybody drinks as much as this particular patient did. I don't think a beer here and there or a glass of wine here or there is a horrible thing for your psoriasis. I definitely don't. But I do think that people that drink quite a bit of alcohol can definitely make their psoriasis worse. All right, and this is a myth that I've heard before, and I think it's come up recently in some of the popular literature. Applying human breast milk will improve plaques. Unfortunately, this is not true. Breast milk, though, it may moisturize the plaque and decrease the scale, but we unfortunately do not have any evidence that this would be successful for psoriasis. And then we have another myth here: tanning beds are a suitable treatment option for psoriasis. To talk about this slide, I'm going to give you a sampling of 2 patients I saw just yesterday. I saw a patient that had guttate psoriasis, and that was the speckly psoriasis that we saw in an earlier slide. She got it from a strep throat infection, but unfortunately hers persisted. She's a 25-year-old woman, and we really wanted to treat her with the ultraviolet light booth in our office, but she couldn't. She was too busy, which is a common thing. I totally get that. And so what she decided to do was use the tanning bed at her apartment. Well, her psoriasis is perfectly clear, and when she was in, you know, I had to have a discussion with her. This is just yesterday. I had to have a discussion with her. You know, unfortunately, you're really increasing your risk for skin cancer, and it's, you know, she's an adult. If she wants to keep using tanning beds to control her psoriasis, then, you know, I certainly can't stop her. But, you know, in the end, we decided, okay, that's what she's going to do, and that's what she's going to do. Wouldn't be my first choice, but I certainly understand it because it does help. However, as you can see here, the American Academy of Dermatology, and really all my experience, falls on the other side, where we really don't want patients to do that unless it's absolutely necessary, because 3 patients after that 25-year-old woman left, I had a 27-year-old woman come in who spent most of her teenage and early 20 years in tanning beds, and I've taken not 1, not 2, not 3, but 4 melanomas off of her just in the last 3 years, and she's only a couple years older than that other patient. So again, I think those 2 patients will illustrate, kind of the difficult situation we're in. And what I would recommend, if you find that your psoriasis is really, really responsive to ultraviolet light, and I'm not against a little bit of natural sunlight, but in Pittsburgh we don't get a lot of that. But if you find that your psoriasis is responsive to natural light, try to get into an ultraviolet B booth, a narrowband ultraviolet B booth at a dermatologist's office, or ask your dermatologist or dermatology PA or NP to look into possibly getting you a home unit of narrowband ultraviolet B. It's far, far safer than tanning beds. It's a controlled dose of ultraviolet, and it can be very effective for some people. So that's out there as a possibility, and I just wanted to let everybody know that. So again, the next slide here, nutrition. Going gluten-free can clear your skin. I think, like I said, Dr. Bourne is certainly more of an expert than me about nutrition and skin and how those sorts of things go together. But the answer to this is maybe. I would say that yes, patients with celiac disease, going on a gluten-free diet can decrease the overall inflammation and help skin. However, I have had many psoriasis patients that do not have celiac disease try a gluten-free diet, and honestly, I haven't seen much improvement. I do believe, though, that if a person has celiac disease, everything kind of gets better. Pretty much all the inflammation in their body goes away. All right, and we're winding down with my part here, and this is a good slide. Vitamin D supplements reduce psoriasis plaques. Unfortunately, we don't have a lot of evidence that the oral supplements do, but we do have a lot of good evidence that the topical vitamin D does help, and that's something you can get in a prescription at your dermatologist's office. And for those of you that maybe don't want to use topical steroids, it could be a really great option. I would say, in my experience, they're not perfect topical vitamin Ds, but they definitely can help, and they definitely have their place. Another myth here, putting commercial dish soap on psoriasis can soften plaques. I would say that that's a little bit iffy. Again, possibly the softening of it could be a mechanism of action here, but I would be a little bit more worried about an irritant reaction to some components of the soap myself. And we can move along here. The scale removal, it is necessary to remove scales from the skin as much as you want to. Unfortunately, that can sometimes lead to more problems. If you can do this through moisturization or topical steroids or other topical medication means, well, yes, removing scale is great. But if you're doing this just through picking at them, like I would probably do, because I'm bad at that, that's really not a good idea. And I have seen some psoriasis patients come in with some pretty good infections in their plaques. So with that, my portion is over, and I'll turn it over to Dr. Bourne.
Terrific. Thank you so much. We're now going to hear from our next presenter, Dr. Todd Bourne. Dr. Bourne is in private practice with his wife at Bourne Naturopathic Associates, Inc. in Alameda, California, where he is the co-owner and medical director. Dr. Bourne is the product manager, director of new product development, scientific advisor for Allergy Research Group, LLC, and editor-in-chief of their science-focused newsletter. He is also a thought leader for the UK-based Clinical Education, a free peer-to-peer service that offers clinicians a closed forum to ask clinical questions and receive evidence-based responses by experts in their field. Dr. Bourne graduated from Bastyr University in Seattle, Washington, and completed his residence at the Bastyr Center for Natural Health and its 13 teaching clinics with rotations at Seattle area hospitals. Dr. Bourne's clinical focus is utilizing integrative medicine to treat chronic disease. He has a strong interest in difficult and refractory cases, gastrointestinal issues, neurological and neurodegenerative disorders, endocrinology, cardiovascular disease and diabetes, autoimmune disease, ADHD, autism, HIV, AIDS, and geriatrics. He has extensive knowledge and training in the basic medical sciences, physical medicine, botanical medicine, homeopathy, biotherapeutic drainage, counseling, and diet and nutrition therapies. Thank you for joining us, Dr. Bourne.
All right, thanks, Corrine. I'd also like to thank the National Psoriasis Foundation for inviting me to be part of this talk, and for Jason for his fantastic overview that he just went through. Before I start in the slides, I would like to kind of preface a few things, that this is just a few examples of some of the integrative medicine or quote-unquote natural medicine treatments that can be used in psoriasis and psoriatic arthritis patients. And it's really just the tip of the iceberg. But again, these should all be used with guidance because the doses are different than what one would normally think of, where they're going to take a few hundred milligrams, because there's preventative doses in medicine, there's maintenance doses, and then there's actual disease treatment doses. So sometimes when someone looks at a natural ingredient or a natural agent and you read the research literature and it's a negative study, many times it's because of its inefficacious dose. It's just not enough of the physical substance, because natural substances do not work like drugs. They don't work like the biologics, but you can make them work in a similar fashion when they're used judiciously. But it really needs to be done with the guidance of an integrative physician or clinician, that someone really knows what they're doing. Also, I will move pretty quickly through the slides because from what I understand, there are a number of questions that a lot of the listeners want answered, and so Jason and I are going to try to get to as many as possible. We would like to get through all of them, so I'll just kind of move relatively quickly through these. Oops. Doesn't seem like I can advance the slide deck from my... So first we'll talk about the gut. You know, the last maybe 5 to 10 years, the microbiome, this catch-all phrase, is becoming very popularized, not only in medical circles, but I think in the general public as well. And here we say people naturally have bacteria, microbes living inside and outside the body, which is called the microbiome. There's literally a microbiome for everything. There's a skin microbiome, there's an eye microbiome, there's a placenta microbiome. Here we're just kind of talking about the gut microbiome. And our bodies have 10 trillion cells, but approximately 100 trillion microbial cells. So there are 10 times more microbial cells that live in our gastrointestinal tract than the rest of our body combined. And the gut alone, which includes our stomach and intestines, is home to about 3 pounds of bacteria. And the way we know now, there's actually the Human Gut Microbiome Research Center. It's through the National Institute of Health. So far, they've been able to count at least 1,000 different microbial species that just live in our gut. Some good, some bad. So the next slide. Here is a top-tier journal of immunity, and it was a study out of 2010 talking about the imbalance of bacteria that lead to inflammatory diseases. And it doesn't necessarily mean that that disease has to be in the gastrointestinal tract, like irritable bowel disease, which is Crohn's and ulcerative colitis. So you'll see this a lot in medicine, that there's an imbalance, which is also called dysbiosis, gut dysbiosis, which means you have an inordinate amount of the bad guys compared to the good guys. And the good guys would be your probiotics. The most famous ones that people are aware of are your lactobacillus and your bifido bacteria. But when those are out of balance, you will actually see people that have a predilection towards some of the diseases. Here we're talking about psoriasis and psoriatic arthritis. So here was a different study that came out actually just last year, that these were patients that had psoriatic arthritis and they were not treated. They were recently diagnosed, and then they did some stool testing on them and saw that these psoriatic arthritis patients had lower levels of bacteria, the good bacteria, and larger amounts of the bad bacteria. And these were similar to groups with IBD, those that have ulcerative colitis and Crohn's. And here, this is actually slide shows mostly prebiotics, so I'll kind of help differentiate between prebiotics and probiotics. So probiotics are these beneficial bacteria that you look at the label, and their lactobacillus is the genus, and you'll see acidophilus and rhamnosus, a number of different species, as well as bifidobacterium in a number of species. But really, the the research is in its infancy on probiotics, is that the race is on to find out new cultures, new strains, get these patented to be able to manipulate the gut microbiome, which then in turn manipulates systemically the immune system, the neurological system, etc. Prebiotics, on the other hand, are indigestible fibers. Those are actually beneficial to make your healthy flora grow. Some prebiotics that are not found in food have some evidence that they can feed dysbiotic organisms like Campylobacter, but you let someone like me kind of do the stool testing to find out what you may be lacking and what the science shows to help you. Probiotics only work as long as you take them. So there is a washout period. As soon as you stop taking them, within a few weeks, the benefits from that probiotic, what they were inferring, no longer exist. That's why the prebiotics work better when they're used in conjunction with probiotics. So the examples of food here, the only one that actually has probiotics would be the yogurt. Kefir, sauerkraut, kombucha, and kimchi, and sour pickles, those have prebiotics. Anything that's fermented will have prebiotics. And again, those are very necessary to help shift out of that dysbiotic phase. Another caveat is that most probiotics on the market are actually contaminated with pathogenic bacteria and or they don't even meet label claim. So it's of the utmost importance to find a probiotic that is of very good quality, that has independent analyses, because unfortunately the supplement industry is not, it's a little bit misleading that one would like to believe that it's not regulated. It's not that it's not regulated, it's that it's poorly regulated. The FDA only has so much man and woman power to be able to help enforce good manufacturing practices that the higher tier supplement companies use. Those are particularly the ones that are only sold through physicians. But there are some high quality supplements that can be found over the counter that are not just sold through doctors. But that's pretty key, is to make sure you get the right one. And people say, well, which one's going to be the right one? You have to contact the company. The due diligence, unfortunately, is on the consumer if they're just seeking it out by themselves. And they really need to contact the company and ask for an independent certificate of analyses that has actually tested it for microbial content, pathogenic bacteria, purity, potency, etc. If that company cannot provide you with that certificate of analysis, then it's not a company you want to be taking any of their products from. So here was a study on omega-3 fatty acids. So for the slide deck here, I just try to kind of pick what the more famous treatments are that people may have used on their own, or someone told them about, or they came across a study. Here was one where these actual individuals were using topical treatment and they added in omega-3 fatty acids from fish oil in those patients that had plaque psoriasis, and they did show an improvement, almost double improvement with those, the control group. The control group only had topical treatment. Essentially how they work is by being anti-inflammatory. But again, the dose needed to really get significant effects needs to be under the guidance of a physician or any integrative practitioner who knows how to use these things, because there could be interactions with the medications the individual's on. High doses of omega-3 fatty acids can thin the blood, so it increases bleeding risk. And really high doses to actually work similar to the TNF inhibitors, it's 10 grams of omega-3 fatty acids. So it's a little misleading on the label when it says, oh, 1,000 milligrams of fish oil. That's irrelevant. What we need to know is the actual active ingredient of the fish oil, which is the omega-3 fatty acids. 10 grams of fish oil is an immune suppressant, and that's partly how it works in psoriasis and psoriatic arthritis, besides just the bleeding risk. So one has to be cognizant that they are going to have some issues with their immune system when left on prolonged doses at that high of a dose. Pycnogenol is a patented extract of the French maritime pine bark, and there's some good studies showing versus placebo, and they have a couple trials that were open label, that taking 50 milligrams 3 times a day improved all parameters of psoriasis. So they had less pain, they had less lesions, less erythema or swelling, less dryness, less plaques, less flaking, and oxidative stress markers, which is a sign of inflammation, were also reduced over time. The only drawback I'd say with pycnogenol is that it tends to be fairly expensive, so one has to be aware that they're going to have to shell out a little bit of money versus some of the generic maritime bark extracts, because pycnogenol is the one that's been used in all the studies. It's actually very well studied in at least a dozen health conditions. Here's an older study out of 1979 where they actually gave people vitamin A when they were also using topical corticosteroids. Here it says the anti-psoriatic effect of vitamin A is either moderate or restricted because of side effects. I think what they mean is more or less those that are pregnant or wanting to be pregnant. You can't use more than 10,000 IUs in a day because that's from supplements and food, and this is preformed vitamin A, not beta-carotene or other carotenoids that can convert into vitamin A, because they can be a teratogen. They can cause harm to the fetus. So that's why we have women that want to get pregnant or are pregnant. They don't take any more than 5,000 IUs a day. There have been newer studies, they're not in this slide deck, showing increased efficacy of oral retinoids in all types of plaque psoriasis. And I would say in my practice, I routinely use very high doses of vitamin A for certain amount of time, a few months, a few weeks, depending on the condition and the person and their comorbidities, and I see fantastic results. But again, you don't want to be loading up on vitamin A just on your own. You really need to be with someone who can guide you along how to use those more appropriately. Next would be a very famous herb, turmeric. Curcumin is the main principal curcuminoid, of which there are many curcuminoids. The problem with curcumin when used as a culinary spice is that it has poor absorption, poor bioavailability, but doesn't mean you're not absorbing any of it. It's better when it's mixed with fat. It's been around for thousands of years in Ayurvedic medicine, which is an East Indian type of medicine that has been using it for anywhere from Alzheimer's disease to dementia, to preventing that, to treating it, to chronic pain. Again, the more pain and symptomatic someone is, typically with natural substances, the higher the dose. I know medications, I prescribe medications all the time. I'm very comfortable with them. I don't prescribe the biologics. I let dermatologists and rheumatologists and people like Jason manage those medications. That's not my expertise, but I can help guide people with those medications. And natural substances can work the same way, where you have to have really, really high doses. At the high doses to see improvements with people, say their pain or their plaques, to have them regress, it's high enough dose to where it can interact with certain medications because it does get processed in the liver, and it can have some theoretical increased bleeding times, but most of those are in rat studies and they're theoretical interactions. I haven't seen it yet, but that doesn't mean that it doesn't happen to somebody. One of my favorite topicals actually is just good old-fashioned aloe vera. I don't think Jason in Pittsburgh has a whole lot of growing where he is, but in California and Arizona, plenty of aloe vera plants. Really needs to be at least 98% pure aloe gel, and you can get it. It's very inexpensive, very low risk of side effects. It tends to be very effective, especially for those that have the really dry type of psoriasis where their skin is very flaky. I typically actually end up combining it with more of as a carrier agent and combining it with other substances to apply topically. If a person has head-to-toe psoriasis, it's difficult, obviously, because you're going through buckets of it and you have to cover yourself pretty frequently with it, particularly after you shower. This was a study in 2010 that actually compared the aloe gel alone with 0.1 triamcinolone, 0.1%, which is a topical steroid, and it actually showed that it was pretty much equivalent to the steroid without the side effects of the steroid, like the skin thinning, fraying of the skin. It works very, very well. I do have some patients that it actually, for some odd reason, it made their psoriasis drier, so we just stopped using it. But again, very low cost, low force intervention. You try it, doesn't work. Really not out a whole lot of money or time. But I do like the phototherapy for people that have very widespread psoriasis. It's a faster way to get coverage and treatment, so I do routinely recommend them to go to dermatology clinics or hospitals that have derm clinic that specializes, so each time you go you're getting more and more exposure of that narrowband BUV that Jason spoke of. Next slide. somehow it went back to the beginning. Okay. So this is a big one, and I'll kind of help what Jason was saying, what his clinical experience is versus my clinical experience, and I'll try to help differentiate between a true food allergy versus a food sensitivity versus a food intolerance, because they're all very, very different. A food allergy, a true food allergy, is mediated by the immune system, and that's kind of the classic scenario. You see someone who eats the shrimp and their face gets puffy, they have hives, scratchy mouth, scratchy throat, maybe a little trouble swallowing, trouble breathing, all the way to anaphylaxis, where they need an EpiPen or they can die. That can be immediate, up within 4 hours, or it can be delayed up to 24 hours. That's a true food allergy. A food intolerance is actually not mediated by the immune system, so it's very difficult to diagnose, and is typically more of an enzyme insufficiency or deficiency. So lactose intolerance is the most common intolerance that people are aware of, where your body has an insufficient amount of lactase, the enzyme, to break down lactose. You rarely see a food intolerance have systemic symptoms. It's mostly just GI located. Where a food sensitivity is far more complicated and far more convoluted in that it may or may not be mediated by the immune system, and people may actually have reactions to the byproducts, basically the breakdown, the metabolites of the foodstuffs that they're eating. Sometimes those can be diagnosed, sometimes they can't. Like, for example, there's a condition called non-celiac gluten sensitivity. Some people have positive antibodies to gluten without celiac disease. They have NCGS. But many more people actually get diagnosed with NCGS and they have no antibodies. So then how do you know if it's one of those intolerance or is it a sensitivity? That's when the gold standard comes in, which is the allergy elimination diet. And what's on here is these are the most common foods that people are sensitive to or intolerant to, that react to. So all my autoimmune disease patients, all my chronic disease patients, they eventually go through the allergy elimination diet. And that means for 2 weeks you have no gluten, no dairy, no soy, no corn, no citrus, no eggs. If they have pain, psoriatic arthritis, I say no nightshades. We remove those for 2 weeks, you keep a journal, and we'll see how the symptoms, do they get worse, do they get better, does anything happen? And then you come to challenge those foods. So most patients typically challenge gluten first, and you have to challenge the food in its rawest form as possible. So you eat whole wheat bread, and you eat it 3 times in 1 day, waiting 72 hours after, because there are delayed sensitivities, and you keep a journal. So if the individual challenges gluten and they say, I didn't notice anything, more or less after 72 hours, if you do not react to that food, the probability of reacting to that food is very, very small. You can consider it safe and you move on to the next. Dairy gets broken up into 3 parts: cow's milk, cheese, and yogurt. I have a lot of patients that will react to cow's milk, but they're fine with yogurt and cheese. My rationale, my theory that I surmise is just the fact that 1, they're both lower in lactose than cow's milk, and 2, they're fermented, so they actually have some fermented foods in there, maybe having some protective mechanism. Same thing with soy, corn, citrus, eggs. There is, and then you kind of see what happens, and I could say I've seen well over 100 psoriasis and psoriatic arthritis patients, and I have yet to see someone not have a food component be a portion of their disease process. So you remove the inflammatory foods, help the immune system become more tolerant, as Jason alluded to earlier, their disease will regress. And everybody's different. I have patients that they can go into remission. I have patients that get 10% improvement. There are more foods than this, but you can't really spend the rest of your life doing the allergy elimination diet. So there is IgG food testing, which is food quote-unquote sensitivity testing. It's not food allergy testing. And it has to be taken with a grain of salt. The best evidence we have for its efficacy are those in irritable bowel syndrome and a condition called eosinophilic esophagitis. But that doesn't mean if I have a child who has psoriatic arthritis or psoriasis, it's very difficult when they go to school to monitor their diet. You can run this blood test and see what comes up. And they are titers, so either they're non-reactive, very low, +1, 0, +1, 2, or 3. So whatever comes up, and you can test for hundreds of foods at once, which is the advantage over the allergy elimination diet. You have them remove those foods for a period of a month, and you see how they feel. And sometimes that's the key when I'm working with patients and say we've been working together for 6 months or a year, and I have their disease 80% in remission, and they're very compliant, they've done everything that I've asked, but there seems to be a key component of the inflammatory process. I do typically encourage maybe an IgG diet or a testing to see what else we can remove that may potentially be helping their disease progress and not regress the way I think it should. And back to Jason's point, that when I talk to my patients that have any autoimmune disease or psoriasis and psoriatic arthritis, what we talk about are flares, and we try to identify triggers to their flares. Because once we get them under control, whether it's just with naturopathic medicine or it's in conjunction with conventional medicine, so I can offset the side effects of the med, or if they're getting sick all the time from the biologic, maybe we have to work in tandem. And that's where integrative medicine really shines, is where you can keep the patient on a lower dose of the drug where it still works, but you can also offset the side effects and they can have an improved quality of life. I agree with Jason tremendously that if you can get people's stress under control and have them have it be an outlet in a more productive and efficient manner, whether that's yoga or meditation or running or playing with the kids or whatever that may be for them, their disease is not nearly as life-altering as those that do not control well for their stressors. And when I mean by triggers, there's lots. There's stress, there's food, there's situations. Once we find those triggers and we try to remove them, people typically do a lot better. And here are some examples. I don't have a whole lot of experience with art therapy or muscle progression therapy or aromatherapy. I think aromatherapy is great when used appropriately for calming, especially if you're going to put, say, lavender and you just need some calming. Journaling is great. For me, I just kind of ask my patients, how do you cope with stress? What ways do you have for stress outlet? And I am not a therapist. That's not my specialty, so I have a list of referrals I send them to for people that will help them along that way. But I think that's a very important thing, and it's non-invasive. It doesn't cost any money, and it as far as breathing exercises or meditation, you can do yoga in your own house. These kind of things, journaling, they're very, very important, I think, to help people have an improved quality of life. Thank you.
Wonderful. Thank you so much, Dr. Bourne. We're now going to move into our question and answer session. And our first question is to Dr. Bourne. Is there any information on the efficacy of fasting in achieving remission of psoriatic symptoms?
That's a good question. I don't know about fasting, any research for fasting and psoriatic symptoms. The best evidence I know for fasting has to do with irritable bowel disease when those individuals are on a flare. And the way it works, and you could just go on to pubmed.gov and just type in fasting psoriasis or fasting irritable bowel disease, and research articles will come up. Essentially, the way it works is that when you go on a fasting state, and whether it's a water fast or a juice fast, I don't do that a whole lot with my patients just because of my style of practice. I know other doctors that they're experts in it to guide them. And the fasting can be 24 hours, 72 hours. If it goes beyond that, you need to be monitored by a healthcare practitioner. But the way it works is by the theory is that you're putting essentially nothing into your body while it's in an inflamed state for the immune system to calm down.
Great, thank you. Our next question is for Jason. Should a person who has had cancer refuse treatment with biologics?
That's also a great question. In fact, I just had this exact question today. I think it depends a lot on the exact nature of the cancer, number one. I think for solid organ cancers, so meaning breast, lung, prostate, thyroid, there doesn't appear to be a huge correlation with, I don't see a huge increased risk with the biologics. That doesn't mean it's zero, but we have studies that go out 5-6 years, and patients that have been on certain biologics 5-6 years, and there does not appear, at least in retrospective studies, to be any increased risk with, or any increased incidence of any of those types of cancers. The only thing that we do see somewhat of an increased risk with in psoriasis patients would be non-melanoma skin cancer, so basal cells and squamous cells. So that being said, I think the huge thing is to get the oncologist on board. The standard is if you're 5 years post-diagnosis and considered cancer-free, that most dermatologists and most oncologists would say, yes, it's okay to go on a systemic therapy for your psoriasis. I think the exception to that would probably be lymphoma and leukemia, just because I have a little bit more of a worry with that. But yes, I think you are able to do that. Have I put people closer to that, meaning 2-3 years post-diagnosis? Once or twice I've treated them with systemics, but I certainly am extremely cautious in those cases.
Great, thank you. Our next question is for Dr. Bourne. Since starting B12 injections last year, my severe psoriasis cleared up and has not come back. Is there any correlation?
I would say that's great, and congratulations. It depends on the type of B12. I could certainly make a biochemical argument for it, but I have not seen that in clinical practice. I do a lot of injections. I use that more for when people have, say, if I'm going to use B12 because they have fatigue, but I don't know a mechanism of why someone's psoriasis would go into remission by B12 injections alone.
Great, thank you. The next question is for Jason. I use topical steroids and then wrap with saran wrap. I shared this with my psoriasis support group and they freaked. Is this not recommended?
Well, I think that it certainly is a good way to increase the efficacy of the topical steroids. I don't have a problem with it on most areas of the body. I think particularly on the elbows, knees, places where the skin is more thick, I think you're fine to do that. If you overshoot it a little bit and thin out your skin in those areas, I don't think it's a huge problem. You do have to be careful in areas like your groin, body fold areas. Certainly I wouldn't do it on the genitals. But I think extremities, back, I think I'd be fine with all of that. But again, body fold areas that you have potential for thinning of the skin, you do have to be pretty careful with that.
Thank you so much. The next question here is for Dr. Bourne. Is acupuncture beneficial for psoriasis?
I would say yes. I'm not a traditional Chinese medicine practitioner, but I use them a lot, particularly for pain. I know Chinese medicine theory, it's not just acupuncture. They use a lot of herbs in conjunction with it, but I do routinely send my patients to acupuncturists, particularly for pain control.
Wonderful, thank you. Next question is for Jason. Can you try different topicals on the feet at the same time?
Absolutely. Feet can be pretty tough. That's another place I should have said that it's fine to use topicals with saran wrap because the skin is so darn thick on the palms and the soles that you're really not going to thin it out to any significant degree. And so if you want to use different topicals on the feet, by all means go ahead, particularly if it's on the soles of the feet. I really have, again, the skin is so thick and so resistant to treatment there, it's just really difficult that the more you can throw at it, the better if you find it to be efficacious. So, feel free, and I don't believe you're going to hurt yourself with that. The only caveat I would say to that is if, occasionally get people that are loading up and hitting it with steroids when really all along they have a fungal infection on their feet, and that can make it worse. Other than that, though, I think you're safe.
Thank you. Next question for Dr. Bourne. Is drinking cider vinegar helpful for sufferers?
Yes, and I would say yes and maybe. The best evidence, again, for apple cider vinegar actually in diabetics because it lowers fasting and postprandial insulin. But I would say apple cider vinegar can help stimulate digestion so you can better properly digest your food so it's less antigenic. But applying it topically, maybe. It's not something I'd regularly prescribe or recommend people doing because it smells. But if it works for you, great. It's a pretty benign intervention. But I agree with like Jason, if someone's missing an underlying infection, that needs to be addressed instead of just lathering with apple cider vinegar. Albeit I do love apple cider vinegar before meals to help stimulate digestion.
And I will jump in on that too, just saying that I've seen apple cider vinegar actually help. Again, I'm not trained in that at all, and it's only anecdotally what patients have told me. I've seen it help a few different skin diseases. The big thing I would say in response to the previous question about occluding it or putting it under saran wrap, that's one thing I wouldn't do with apple cider vinegar topically. I think it could definitely lead to some irritation. I actually have seen that.
Thank you. Next question for Jason. Since I had a bad reaction to Humira, should I stay away from all biologic or just those in the same family as Humira?
That's a really great question, and this is definitely something up my alley as far as what I've studied the most and what I am most informed about. My opinion on that is, depending on the reaction, if it was anything approaching anaphylaxis, you'd want to stay completely away from all of the TNF inhibitors like Humira. So if you had swelling of the tongue or swelling of the lips or any breathing difficulty, I wouldn't go anything in that family. However, the newer biologics, and I love the TNF inhibitors very much, but the newer biologics block more specific proteins in the immune system, more specific cytokines. And because of that, they do have quite a different mechanism of action. So you could absolutely have had a reaction to Humira and be completely fine with something like Stelara or the newer ones, Taltz and Cosentyx. You could be completely fine with them. And I actually have had a couple of patients in this exact scenario. So I think you're okay there.
Thank you. Next question for Dr. Bourne. Is sugar a trigger for both skin psoriasis and joint inflammation?
Well, I think it's dose dependent. I mean, anytime you have a carbohydrate, it breaks down into sugars. So to avoid the white carbohydrates, simple carbohydrates like your white flour or simple sugars, then they can act as a flare. So everything in moderation. If my patients are sitting there eating, sweets all day and they have a really poor diet, it does typically tend to make them feel worse. So I think it's very individual.
Okay, thank you. Next question for Jason. Would taking any biologic for psoriasis control prevent me from future platelet donations?
Not that I've heard of. In fact, I don't know if you can do it while you're actively taking it. I haven't heard any research on that, but certainly once you're off of it, I would say for about 5 half-lives, so whatever the medication is. So it's typically a week to 3 or 4 weeks. I think you'd be able to donate platelets. I think you'd be fine.
Thank you. This question is for both presenters. Has cannabis been shown to be beneficial for psoriasis or psoriatic arthritis?
Jason, you want to take the first stab at it?
I have not come across a lot of research on that. I did have one patient, anecdotally, who definitely feels like it helps his psoriatic arthritis. I probably have more that have tried it, but haven't shared that with me. As far as the skin goes, I have not personally had any patients with that, and I'm not aware of any studies about that, but I could be wrong. I will say that, certainly for all aspects of pain, I do think that there's a lot of evidence out there that cannabis can help, probably more than our country gives it credit for. But again, that is absolutely out of my field of expertise, both personally and professionally.
Yeah, and I'll chime in. And I know of no evidence that cannabis can help, say, with the psoriasis, but it is well established in the literature that it can help with pain control. And now there's this new constituent called CBD, which is cannabidiol, which doesn't have any of the psychotropic effects of cannabis, but can have a lot of the pain modulating effects. And I do have some patients that have CBD. They purchase on their own the CBD because it's not illegal. There's no illicit substance in there. On their own, as in roll-ons, and they swear by it topically for their psoriatic pain. I haven't had a whole lot of patients use it yet internally. I mean, the substance, that if you just go into PubMed and you type in CBD, in the last 3 years is when you're really going to see all the literature explode in it. So, but as far as cannabis itself, I can't really attest to its efficacy.
And Dr. Bourne, where would a patient get CBD? Where would they be able to order that up at, since it's not illegal?
Most, well, I live in California, so medical marijuana is legal here, so any of the dispensaries you can get it at. You can buy it online, but again, if you buy it online, there's really no guarantee that you're getting a high-quality substance, so it's another one of these buyer beware. Most dispensaries have it available now, and the race is on between the nutraceutical industry versus the pharmaceutical industry of who's going to get the rights to distribute it first.
Great, thank you. Next question for Dr. Bourne. I'm interested in supplements, but want to know how they interact with prescription medications.
It all depends on the medications and the supplements and the ingredients, and then you'd have to, preferably you go to someone like me or someone who's an integrative or holistic physician that has training to be able to interpret that information. So it kind of all depends. The overarching caution would be if someone's on an immune suppressant drug, you don't want to do things, natural agents that are immune stimulants. Immune modulators are one thing, but we would use immune stimulants with caution.
Great, thank you. Next question for Jason. Can biologics prevent or delay cardiometabolic effects of psoriatic disease?
Well, that is certainly something that I think people are looking into right now. There was a great study done, I believe, at UCSF a few years ago, where patients that were on a TNF blocker, Humira, actually had a 50% decrease in MIs compared to control groups. Again, this is not a randomized, controlled, prospective study, but it still was a pretty darn good study. And I will say that the evidence is definitely leaning towards TNF blockers in particular, but I think it's eventually going to show the other biologics, because they control inflammation, or because they decrease inflammation. The theory is that yes, they will contribute to improvement of other cardiometabolic risk factors. Now, do I feel like that clears out a fatty liver? You're probably not, but I think there are some sort of general improvements that can help with, and I think a lot of those have yet to be elucidated.
Great, thank you. Next question for Dr. Bourne. Are dead sea salts effective for psoriasis?
I do have some patients that use them just because it helps kind of soften their skin. Maybe they'll put them in their bath. But again, just making sure that, to use it judiciously so it doesn't dry out your skin, but it can be a natural exfoliant, which I have seen it help with people's lesions.
Great, thank you. Next question for Jason. Since starting biologic, I've noticed more pronounced discoloration on the skin. When will hyperpigmentation areas regain their pigment?
Yeah, that's a tough thing, and a lot of that has to do with your skin type. If you're a very fair person, it'll typically go away a little faster, but darker skin types, unfortunately, tend to retain that pigment for quite some time. I would say that once the plaques are clear, the average time for the pigment to fade is about maybe 3 to 6 months. But for darker skinned individuals, I've unfortunately seen it not ever fade. Although it will get better, it might not get totally clear. The one thing I will say is anytime you have that post-inflammatory pigmentation, like it sounds like you're talking about, sunlight only hurts that. So sunlight can actually darken that pigment. So wear your sunscreen, particularly in those areas that you have that pigment.
Thank you. The next question is for both presenters. Have you had any success in treating plantar psoriasis without using methotrexate or soriatane?
My quick answer is yes. And that's based
My
upon
quick
everything we talked about. Sorry, that's everything based upon what we talked about before. So in naturopathic medicine, it doesn't really matter the location or the type of psoriasis. The interventions and strategies are still the same, with treating the gut, treating the skin, and inducing immune tolerance.
And I totally second what Dr. Bourne said there. Even in my practice, I tend not to focus specifically on the type and location of the psoriasis. I focus more on the severity when choosing a treatment regimen. Palms and soles are very, very difficult, and really the main successes that I've had have been with biologics in those areas. I've done some other things like injecting intralesional steroids and things like that, but you can imagine how comfortable that is. Occasionally, ultraviolet will help in those areas, and certainly there are light booths that are just for the hands and feet, but those can be somewhat difficult to find, and also they're not always effective. But yes, there are things out there.
Great. Next question for Dr. Bourne. Does natto, or Japanese fermented soybeans, have any prebiotic and or probiotic qualities?
They do when they're taken as a food, which you don't really see a whole lot in the United States. When it's taken as a supplement, for example, vitamin K2, not K1, that's a different form of vitamin K that has a different mechanism of action than vitamin K1. That's made from natto, which is fermented soy. But if someone's eating as a food, yes, by all means. But in a supplement, you're not going to get any of those prebiotic or probiotic effects.
Great, thank you. We have time for one more question here, and this one is for Jason. What are your thoughts about using tanning salons that have beds with UVB rays?
Well, I think if you can find one and you know that that's what they're using, that is absolutely preferable to the typical tanning salon where they have UVA and UVB rays, and unfortunately a lot of times you don't know the dosage of it. You know, this is one of those things, as a whole, as a dermatologic community, we are very much against tanning beds and too much ultraviolet light and that sort of thing. But there also comes a practical side of things where, you know, the risks that you might incur to treat something with ultraviolet light are far outweighed by the benefits. I mean, if you can't live your life because of your psoriasis, and the thing that best treats it is ultraviolet light, and you know, maybe at one of these tanning beds, you know, I would never blame somebody for doing that. Again, it's probably not the best option, but it might be the only option. What if you're a single parent with 2 jobs? I mean, you're not going to be able to go and, you know, find a great narrowband UVB booth at your doctor's office. So yes, that's the long answer. The long answer is what I just said, and my short answer is yes, it would be better if they had UVB booths, and if you can find that, great.
Terrific. Thank you so much. And before we adjourn, I just wanted to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. If you have any other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. And as a reminder, we are having our free goal setting sessions for the month of October, and here's all the information you need to contact them. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate it if you can complete that and provide your feedback. And once again, we want to thank Eli Lilly and Celgene for sponsoring this program. Thank you to everyone, and we hope you have a lovely evening.